Well, folks, welcome to Advances in the Management of Renal Cell Carcinoma presented by Albert Einstein College of Medicine at Yeshiva University at OMed Live. You are tuned into today's first session titled Selecting First-Line Therapy for Patients with RCC. My name is Dr. Naomi Haas, and I am Associate Professor of Medicine at the Hospital of the University of Pennsylvania. Today's session is a live interactive program that allows us to take questions in real time through this presentation. I encourage you to send us your comments anytime by typing them in the box located at the lower left-hand side of your screen. I'd now like to introduce our first faculty member, Dr. Lauren Harshman, Assistant Professor of Medicine at the Harvard Medical School. Lauren, thanks so much for joining us today. I'll now hand the program over to you to begin our discussion.
Thank you, Naomi. It's a pleasure to be here, and I welcome everybody as we discuss selecting first-line therapy for patients with RCC. So over the next half hour, I hope that we will be able to cover the biology of renal cell carcinoma, examine the current treatment landscape of metastatic RCC, and discuss some of the selection challenges given the now plethora of options for treatment. So where do we stand in 2014 in advanced RCC? Unfortunately, we still have over 30,000 deaths annually from RCC in the US. We now have 8 FDA-approved agents to treat the disease, yet 7 of them target the same hypoxia-inducible factor pathways. Median survival has more than doubled since the interferon alpha era, and 80% or more of patients achieve some degree of clinical benefit, whether it's in some degree of tumor shrinkage or prolongation of disease stabilization. But unfortunately, we still have few cures, and efficacy often comes at the expense of significant toxicity. And finally, we still have very limited selection and prediction criteria to help us choose that optimal agent that will ensure responsiveness and avoid futile toxicity. So what I hope to show you is that RCC is a very heterogeneous disease with several major subtypes. Mutations have been identified in many of the subtypes, and these represent potentially druggable targets. Clear cell disease is the most common type of RCC, representing about 75% of all RCCs. And the great majority of those tumors have either a mutation or functional inactivation in the von Hippel-Lindau gene. And this can cause increased expression of proteins that drive angiogenesis and other growth factor pathways. Several of the other less common subtypes we've identified mutations, such as papillary type 1, which is about 5% of all RCCs. Mutations in the c-Met proto-oncogene have been identified in some of those. In papillary type 2, which is another 10% of RCC, there's some degree of mutations in the Krebs cycle fumarate hydrogelatase gene. And finally, in chromophobe RCCs, which are a rarer type, about 5% of all RCCs, mutations have been found in the folliculin or Birt-Hogg-Dubé gene. And so as we talk about some of our available drugs in RCC, I like to think about the major molecular pathways that we are targeting. So the 3 major classes of drugs that we use today include immunotherapy and the so-called targeted agents, which include the VEGF inhibitors and the mTOR inhibitors. As I hope to show you, I think immunotherapy still has a role in RCC, especially high-dose IL-2, which remains one of our only agents that can induce cures in a select group of patients, and there still remains a role for interferon alpha. In terms of the VEGF inhibitors, what you see up there in the middle of the screen is the VHL gene. When that is mutated or functionally inactivated, we get upregulation of hypoxia-inducible factor genes like VEGF and platelet-derived growth factor. And we now have several multi-tyrosine kinase oral inhibitors such as sorafenib, sunitinib, pazopanib, and axitinib that target these receptors. We also have an antibody, bevacizumab, to the VEGF ligand itself, which has been shown to be effective. And finally, we have that second class of agents, the mTOR inhibitors, the IV drug temsirolimus, which is a prodrug of rapamycin, as well as an oral inhibitor, everolimus. And what we wonder whether this is a completely separate mechanism action through inhibition of the mTOR pathway, or whether it also is through HIF, as mTOR can regulate hypoxia-inducible factor. And in fact, this is also through that these agents work through inhibiting the VEGF pathway. And I think what this slide or cartoon really shows to me is that we've really had an explosion of treatment agents in the last 7 years that has, in no doubt, really moved our field forward and helped our patients. And this slide also sort of shows the degree of improved outcomes that we're seeing with the targeted therapies. On your left is data from the interferon era. And in that time, investigators at Memorial Sloan Kettering looked at their groups of patients that had been treated mostly with interferon-based regimens, about 670 patients, and said, why are some patients living closer to 2 years, others living less than 6 months? Can we predict who those patients are? And so they found that there were certain clinical factors that portended a worse prognosis. These included the absence of prior nephrectomy, meaning patients were presenting with metastatic disease, poor performance status, anemia, high serum corrected calcium, and elevated LDH. And if patients had none of these risk factors, they had a much better median overall survival, closer to 20 months, compared to patients that had 1 or 2, it was cut in half to 10 months. And those patients that had 3 or more poor prognostic factors lived 4 months on average. So now that we have all of these different targeted therapies, Dr. Heng and colleagues at the International Metastatic Renal Cell Database Consortium said, do these clinical prognostic factors hold true in the era of the targeted agents? And they were able to validate all of the MSKCC prognostic criteria except for LDH. They also validated 2 new criteria, or identified new criteria that had been seen in certain series before, including neutrophilia and thrombocytosis. And again, what they found was that if patients had none of these risk factors, they had a median overall survival that was much better, and now closer to or over 3 years, which is significantly better than the interferon alpha era. If patients had 1 or 2 risk factors, this was over 2 years at close to 29 months. And again, those patients with poor prognostic factors, 3 or 6 criteria, really doing much worse at 9 months on average. But again, much better than the 4 months we were seeing in the interferon alpha era. So median overall survival, I would say, has more than doubled in the last 10 years. We now have validated clinical prognostic criteria, but these still do not truly direct our selection of the most appropriate agent, and we're in dire need of predictive biomarkers to do that. So as we talk about some of the available agents, I'd like to put it in the framework of selection challenges. These are just a few of the top challenges that I think we see in the clinic. So the first thing we'll talk about is, now that we have 5 FDA-approved VEGF inhibitors, which one should we use first and why? Is a VEGF inhibitor preferred over an mTOR inhibitor? Is immunotherapy still relevant? And what is the optimal agent for non-clear cell disease? And finally, we'll touch upon when clinical trial is reasonable, if at all, in the first-line setting. So moving on to selection challenge 1, which VEGF inhibitor should we use? I don't want to throw 5 different sets of Kaplan-Meier curves at you. What I've put up there are the data from the 3 big registrational trials for sunitinib, bevacizumab plus interferon alpha, and pazopanib. And what I think we can take from these agents in the first-line setting is that they're broadly efficacious. More than 80% of patients are achieving some degree of clinical benefit. Median progression-free survivals in the first-line setting with these drugs are around 10 to 11 months, and objective responses are seen in 30 to 47% by traditional RECIST criteria. But we have little data about best sequence, which should we use first, bevacizumab, sunitinib, pazopanib, and sequential use has probably confounded any clear overall survival benefit. And we know that this is not a cure-all, that there are still 20% of patients that will be non-responders or have primary treatment for refractory disease. So our best data on choosing one of these agents is with pazopanib versus sunitinib. Now, sunitinib was the second targeted therapy to be approved after sorafenib. It is perhaps the most widely used first-line drug in the US and across the world.